All right, welcome to episode 43 of the Researching Happy podcast. My name's Matthew Iasiello. And today we're going to try something a little bit different, which is talking through a model that we talked about a lot on this show. It's called the dual-continua model of mental health. And I want to talk about it for a few reasons. So, on this show, we really want to ask tough questions of the field across wellbeing science, across disciplines. And one really important question, I think that's still semi-controversial, is this idea of how is mental well-being related to mental illness. So we've been talking a lot recently about having debates, and we've got a debate planned and getting scheduled. So I'm really excited to introduce that when it comes time. But this topic, it's obviously close to me. People who have been watching the show, it's the topic of my whole PhD. It's something that we've published a lot on with our team. And, I was watching my favorite podcast, basically, my favorite podcast, which is called Bad Friends. It's a couple of comedians just being silly, basically. But one of them, whose name's Andrew Santino, who you may have heard of, talked a little bit in this latest episode about living with depression. And I think it's a perfect example, and I've got a clip that I'll show you in a second. It's a perfect example of what, the dual continuum model really looks like, this idea that mental well-being is related but distinct from mental illness. So going back to debates, I wrote my first ever rebuttal or a response to a paper that I really disagreed with. And I'll cover off a bit of that story as well. And basically what that paper was saying is that we should think about mental well-being and mental illness as opposites of each other, and that doesn't interrupt the goals of the positive psychology movement. I strongly disagreed with that paper, and I still disagree with it. And there's a response and a response to response. So I'll link to all that and we'll talk through that. But first, let's watch the clip and let's talk about what this means.
When you get low, you get low.
Yeah.
Right? And there's always like a 12-hour period where it's like we just know not to.
Yeah.
But what happens to your mind there?
Well, I have clinical depression, so I go into a deep, very dark, low hole.
Yeah,
I disappear.
It's scary.
Yeah.
I feel so bad for you.
Well, thank you.
Not being real.
No, if I'm being honest, if we want to talk real shit, yeah, I have depression. I get extremely dark and low. I think the worst negative thoughts, I'm sure there's fans that have exactly what I have. And I find that if I can go and exercise or just break away for a second and just kind of do my own little thing, it helps me reset my bearings, and then I can get back to it. And I've done it a few times with you guys. I found the tools for me to go.
All right, cool. So what he was talking about there, just as he was finishing off, he was talking about the tools that he has to kind of mitigate these moments of depression and sort of get back on track, as he says. And so I think just as an introduction, there's kind of three big takeaways that I think are so important. And then after we get past those, you can, if you don't want to hear the sort of the sciencey side of it, you can stop there. But for those who want to know more about it, we can keep going. So the four big takeaways that I've sort of given myself some notes about. So basically, this is someone who is living with depression, which is what they call recurrent. So it's something that comes in periods. But he's also someone who has high levels of well-being. In my opinion, we should let obviously Santino decide that for himself. But from the outside looking in, this would be someone who lives with high levels of autonomy, feelings of connection, of belonging, of purpose, achievement, positive emotions, who would overall be satisfied with his life. Again, I'm assuming. So this is really where this is the second point. I guess it calls into question that relationship between mental illness and mental health, because for the longest time, we've assumed that these things are opposites. You either have a diagnosed mental illness or experiencing symptoms of mental illness, or you have high levels of well-being. You kind of one or the other. And this binary approach, in my opinion, really holds the field back, which we'll go into. So the third point is that he has activities that work for him. So he talks about, that was a sort of an abridged clip, but he talks about, when he's feeling this way, he kind of secludes himself. He tries to exercise. He's found the activities that work for him in his life to help get him, back on track. And the fourth one, which I think is a really easy one to miss, but I also think it's a really important one as you go and have a look. I think the episode is called Rat Island. And just as a side note, they're talking about their time on their Australian tour, which happened recently, and I was there at the show. They were talking about the Adelaide show, which is always nice. I think this was kind of in the context of this moment. So that's obviously where I'm from. The easy part to miss is that Bobby Lee and Jet Ski, as she's called, their co-hosts, are talking about not knowing what to do in these moments where Santino is experiencing this bout of depression. And I think there's something really important there, which is that in my opinion, the friends are there. Obviously, they're there for support. They're there for non-judgment and to be there, but they're actually there for well-being. And if you start to think about mental illness and mental well-being as something separate, it kind of broadens out the activities that are available. So thinking about if you had a friend who's got, a really, like a heart condition, for example, as a friend on the sideline, you're not there to replace, the doctors. The doctors are there to prescribe medications or surgeries or whatever it might be. You obviously have no part in that. But if they say, well, I want to start exercising, or can you come with me for a walk? Well, that's where you're there for. You're there for the health side, not necessarily for the mental illness, for the illness side. And the same is true here. People, I think, when they hear of someone with a mental illness, they kind of back away, they're from maybe even their friends, because they say, well, I don't want to do the wrong thing. I don't want to say the wrong thing. I don't know about this stuff. I'm not a professional. And in some respects, that's true. But what they're missing is you are there for the well-being side of things. You're there to promote well-being. So hopefully that makes sense without too much background on the model. We're going to go into that now. If people want to pause and they're just happy with that, absolutely fine. But let's keep rolling. So basically, this is the dual-continua model of mental health. So as you will have heard many episodes, and including the episode with Professor Corey Keyes himself, this is a model that was really made popular by Corey Keyes. It had been spoken about in previous papers here and there, but Corey really did an amazing job of testing this model using a large American data set, and basically demonstrated that mental well-being, although it's related to mental illness, is separate. So when I was just setting out in the work that I was doing, we really, because well-being sort of wasn't really believed, and it was almost perceived as like, stepping on the toes of psychology when we went out to workplaces and stuff like that. We were really clear that, we do the well-being promotion. We work with sort of the general population and try and make them happier. We don't do anything to do with mental illness. But then we started measuring distress in the workplaces that we were going to. And of course, we were seeing high levels of distress in basically every, workplace, sort of that idea of 1 in 5 Australians would be diagnosed with mental illness, that kind of idea. And so we had to get a little bit more nuanced with, what exactly we were talking about when we were talking about, a general population, because there is no sort of generally healthy population. And I remember at the time thinking that there was this big gap in the evidence around some of this work, because people were they knew about some of these ideas, but it hadn't really sort of made its way into mainstream in any real way. And I remember talking with a good friend of mine over dinner and talking about this model, because that's what I was doing at the time, just basically chewing everyone's ear off about it. And I remember him saying, like, really, I remember the night exactly. We were eating burgers at the beach, basically, and he said, I've actually had anxiety for a long time, and I've actually never thought about my well-being. I've never thought about the fact that I'm in a loving relationship. I've got really close mates. I'm really like what I do at work. I'm achieving. I'm connected. I've got sense of belonging. It just hadn't occurred to him, basically. And I think in my mind, it's because we've really thought about mental health in this binary way. You either you have a mental illness or you don't, and you're mentally well. And so he had obviously put himself in that category of I'm someone with a mental illness, and kind of the ideas of mental well-being had kind of just slipped him by in a sense. And so what I did as the start of my PhD was to do what's called a systematic review or a scoping review of the evidence supporting the dual-continua model, because I was really interested in sort of the implications of what would this actually mean. Because the idea is that basically our healthcare system is based on this assumption, or our mental health care system is based on the assumption, not that anyone really believes it necessarily, but it's built on this assumption that, if we think of mental illness ranging from, -10, and then there's kind of 0 where you're neutral, and then there's +10, which is high well-being. The idea is that if we just reduce and treat and manage symptoms, that will build well-being, which is, of course, not exactly the case. So that's where I've called this title of the episode, The Hidden Truth About Mental Health, How the Dual-Continua Model of Mental Health Changes the Game for Promotion, Prevention, Treatment, and Recovery, which is kind of like all the areas to do with mental health promotion and mental illness treatment and recovery. And so what I was really interested in was, is there evidence? I knew that Corey Keyes had done this work, but is there evidence supporting this dual-continua model of mental health? And basically what we found was, nearing on 90, it's probably over 100 now, papers that had tested this relationship and by and large had found that mental illness and mental well-being are separate concepts. And they found this through a range of ways. And so at the time, I guess, when I was just starting out, this model by Felicia Huppert, who just passed away late last year, who's an absolute giant in the field and was well respected and well loved. She had written this paper in, I think, 2005 as well, talking about this idea of shifting the population curve. That if we have this kind of normal distribution from mental illness through languishing, moderate mental health to flourishing, if we can kind of shift that population curve towards the flourishing end, we'll have less people in the mental illness space, which I believe is true at a population level, but it has within this diagram that you see for people who are watching, an assumption that there is this linear sort of pathway that people pass through from, flourishing to moderate mental health to languishing to mental illness. What it doesn't allow is the fact that it's possible to have high levels of well-being with a mental illness. So you can't kind of be at 2 points of the line at once, which is kind of the big assumption that Keyes's model really pushes against. So I was really interested and pleased that James Pawelski from University of Pennsylvania, he had done a sort of a philosophical consideration about the possible relationships between positive and negative, just as concepts. And we'll obviously apply that here to positive mental health and, negative being mental illness. Not that I mean, positive and negative, but just the idea of what could they possibly mean? And so it's been a little bit of time since I've gone through these slides, but let's just walk through them and just bear with me. But basically the first option that Pawelski comes up with, or that he describes in 2016, is this idea as positive as the absence of negative, which is this idea where you kind of go from -10, which is maximally negative, meaning the absence of positive, where you go all the way through to 0, where you're sort of saying, well, this is maximally positive because there is no negative. So this would be saying basically that there is no well-being, there's only mental illness. And so when you feel no mental illness or no symptoms, then you're well. That's not really a popular model. That's never been sort of used here. Although it's kind of the assumption of the mental illness symptom, which is that if we treat mental illness, we'll end up with a well society. The second option kind of extends that number line. So rather than going from sort of -10 to 0, it's thinking about positive and negative as polar opposites. So in that first option, we're kind of thinking about positive, almost like positive doesn't exist. It's only the absence of negative. A little bit like heat and cold, this idea that cold doesn't exist, only heat physically exists. Cold is just the perception of no heat. In the second option, we're talking about sort of extending this. So we are saying positive exists and negative exists, and they're polar opposites of each other. So negative is as -10, positive is at the +10. And this is, I guess, what I was kind of arguing that positive psychology has done, is extended the number line. So rather than finishing at 0 with the assumption that that means you're well because you don't feel any mental illness, we're now extending that positive, that number line, so that you can actually aim for +10, which would be maximally positive. This is kind of now, I think, the idea that's very popular still. It's kind of the underlying assumption, a lot of the research that happens, and it's the sort of the underlying assumption, say, of Felicia Huppert's model, where you could be sort of anywhere along this line, anywhere from -10, maximally negative, all the way through to maximally positive. Option 3 is the idea of positive and negative being distinct dimensions. And I really recommend going and having a read of James's papers. I think there's 2, part 1 and part 2, Pawelski, that is, because he talks about this really interesting idea. I mean, I find it interesting about the confusion of 0 in this second option. Because what he's saying is, in this model, we can't tell whether 0 here means that you feel no positive and no negative, or that you feel equal amounts of positive and negative. So, you've got +5 and -5, that brings you back to 0. And so this is really the point that I've raised, and I'll go into it now. This idea that if we think about mental health and mental illness in this, what they call bipolar approach, option 2, I probably recommend watching this if you're on Spotify or on YouTube, because you can see the slides that I'm working through. But that confusion, the fact that this bipolar model masks those two potential experiences, is the reason why we need the dual continuum model. So just to be super clear here, the fact that when we think about it as a bipolar model does not help us understand whether we're feeling equally negative and positive, or none, 0 of both, is the issue, in my opinion, with this model. So the third option is then considering positive and negative as distinct dimensions, which is really the big innovation that Keyes really helped push forwards. So under this approach of the dual continuum model of mental health, each concept, so mental illness and mental well-being, can be described independently of one another and can be tested and measured separately. Individuals can be, it basically allows that individuals can be mentally healthy and mentally ill at the same time, which is that issue of neutrality of Cacioppo and Bernstein, which we'll talk about in a moment. This approach, there's again a paper by Heron and Trent from the year 2000, where they walked through the sort of the philosophical benefits of, or the conceptual or theoretical benefits that a dual continuum model would have if we had it. And some of these are listed here, which is that, by thinking of these things separately, individuals can actually disclose information about their mental well-being whilst holding confidential information about mental illness, for example. Then there might be scenarios where that's useful, particularly workplaces and places where stigma still exists. They pointed out, and we now since have evidence for this, that considering these two things as separate actually provides new avenues for proactive rather than reactive care when we're thinking about mental health promotion. And that's the big knock, I guess, on the mental health care system, is that it is reactive. It waits, and I don't mean it in a cynical way, like it basically, we don't have many options for you until you have a mental illness, and then we have options for you. The issue is that a reactive system like that can't do anything to prevent. It can't do anything to reduce the incidence of mental illness. And, as it stands in Australia, we don't even have the resources really to support all of the people living with a mental illness. So this idea of a reactive system is something that really needs to shift. And I believe the dual-continua model is a huge driver in the sort of the theoretical rationale for shifting that system, if you even need one to begin with, because I don't think anyone disagrees with anything I just said. And the last one is that it allows for thinking about them separately, allows for us to identify the unique antecedents and predictors of each of these things separately. So the idea here is that there may be, and again, we'll talk about, there's some papers that have demonstrated this, there may be unique drivers that influence mental illness, but not well-being, and vice versa. And if we don't think of them separately and at least allow the opportunity for both of these things to occur, then we'll just mask these findings again. So we kind of assume that, well-being, the things that drive well-being also reduce mental illness, and the things that, create or cause mental illness then reduce well-being. If we build that into our assumptions, we'll never find anything different, basically. So you've got a bit of reading to do now. You've got Heron and Trent, you've got Keyes, 05, 02 papers, very, very widely cited. You've got Pawelski's paper, you've got Huppert's paper, so you've got a bit of reading to do. And so going into the kind of the debate side of these things, where I was, I guess, disappointed to see this paper coming out in the Journal of Positive Psychology, which is titled From Ill-Being to Wellbeing, Bipolar or Bivariate. And so bivariate is the model that would describe the dual-continua model. And these are very well-respected authors in a respected paper. Why I don't have any issue with their results or anything like that, but what really probably, I guess, upset me sort of academically was this kind of conclusion that they came to. So they found that in a population of people, when they measured distress, or I think it was depression, and they measured well-being, they found that these two things did look very, very similar. Basically, they did act in a bipolar way. So I'm not even going to contest their results. I'm going to contest the conclusion, really, which is what I wrote that response paper. They say that they highlight, reading here, we highlight how bipolarity does not contradict the goal of positive psychology, nor does it disagree with the notion that well-being is not the absence of ill-being. And so that first sentence there is a bit that I was really contesting, that it doesn't interrupt the goals of positive psychology. And so in our response to that paper, which is, not really my style, to be kind of argumentative, or maybe it is, I don't know, but I don't think it is generally. This was our first response paper where we basically, we titled it, let me just zoom in here, Positive psychology is better served by a bivariate model than bipolar conceptualization of mental health and mental illness, a commentary on Zhao and Tay. And for some of the sort of the theoretical reasons that I've already sort of outlined, this is the stuff that I really disagreed with. And what I lent on very heavily was this really, really insightful paper by Cacioppo and Berntsen from 1994. I think I actually figured out that I remember, again, having this kind of what I thought was my own little brainwave when I was writing the methods chapter of my thesis. I think John Cacioppo actually passed away basically it would have been like within the same month that I was kind of like having this huge insight from his paper. And so you never know as a researcher, I think, how influential you might be in the future, or the impact that, even if he were still alive today, the influence that you can have on someone else. And so this was a huge thing for me. But really what they talked about was, again, the relationship between positive and negative. And what they talked about were the principles of a bipolar relationship, compared with the sort of the principles of a bivariate relationship. And so I kind of took their approach and just discussed it in terms of the dual continuum model of mental health. And this is where it's been a little while since I've looked at this thing, but the idea is that if we were to graph, mental well-being from high and low and mental illness from high and low, what we assume in a bipolar relationship is that what they called reciprocal coupled activation, which is basically saying when well-being goes up, mental illness goes down. They also outlined that there are lots of other potential relationships that exist between mental illness and mental health, which is what they called uncoupled activation. So this would mean, moments where mental illness goes up, but mental well-being stays constant, and where mental well-being goes up, but mental illness doesn't change. And really the big takeaway, I think I've said it now a few times, is that if we assume that the bipolar model is true, and there are times where it is true, right? And that's why I don't contest the results of of that paper that I was responding to. I don't have a problem with their results because they did see a bipolar relationship. My problem is that when you assume that that is true in every case for every mental illness in every population, you've disqualified the opportunity to find anything else. On top of that, and I've probably skipped through some of the benefits of the dual continuum model and some of the insights that it builds, so maybe I'll go back to that in a second. But we've found, for example, there is a paper from the Netherlands by Trompeter, I think it's 2017, where they looked at they basically tested these two ways of thinking following an intervention. So they got a bunch of people to participate in an acceptance commitment therapy intervention. And in the original paper, they basically said, on average, people improved in their well-being, and on average, they reduced in their mental illness. That's what you would expect from a bipolar relationship. So that's that reciprocal coupled activation. When one goes down, the other goes up. But then they looked at it again at the individual level. So they looked at so that was at the kind of the group level, that first paper. The second paper, they said, what about individuals? Do individuals do both? So the ones that improve in their well-being, does their distress also decrease? And I don't remember the exact numbers, but basically what they found was that's not the case. They found evidence of this uncoupled illness or uncoupled health activation, as you see on the slide. This idea that some people had meaningful improvements in their well-being with no change to their distress. Others had meaningful improvements in their distress with no meaningful change in their well-being. And some had both. I think roughly it was like a 30-30-30 split, something like that. And I mean, it's just incredible. Now, the thing about that, I guess, is that something like acceptance commitment therapy, it is a broad therapy that I think does include things that would promote well-being and would reduce distress. And this is the frustration, I guess, is that because we've assumed this bipolar approach for so long, we have no idea which things do what. We don't know what improves, in something like acceptance commitment therapy, which has elements of mindfulness, it has elements of acceptance, of sort of more clinical therapeutic cognitive strategies. Which of these are the sort of the active ingredients to improve well-being, and which of them is useful for distress? But the fact even that was the case, I think, to me, is a big blow in the idea of the bipolar model. And again, I'm really wanting to be quite charitable, I guess, in the sense that, yes, in most cases, particularly for well-being and depression, which kind of look the most bipolar, you will find that this is the case. But I don't want you to just sort of to disqualify the opportunity of finding anything else, because I imagine that there are lots of scenarios where that's not the case. And looking back at Andrew Santino, that's someone who's living with depression and has a high level of well-being. I'll go back to that in a second, because I think the time window that you consider is also really important. But the second paper I'll reference is by Kinderman in 2015, where they basically looked at that population level and to try and understand, what are the things in a society that predict mental well-being and what are the things that predict mental illness. And I think they use quite complicated statistics to try and pull apart, what are the things that are uniquely related to well-being and what are the things that are uniquely related to mental illness. And basically what they showed was that there were quite clear differences in the things that promoted well-being versus the things that promoted mental illness. And again, now thinking about promotion, mental health promotion. We know that that's so important. It's basically the theme of this whole podcast. We want to know, what are those things? Because there might be populations where, mental illness prevention is not that important. Resources are limited. So let's focus on promoting well-being. And the opposite is also true. There might be populations where mental illness is high risk, and we want to understand what are the unique predictors of mental illness so that we can be there for early prevention and intervention. So hopefully I'm making the case that understanding the nuance between these two things is really, really important, and not just something that, I'm being sort of, theoretically stubborn about, or kind of like perfectionistic or something. And so in the commentary, what we basically say is that the bipolar conceptualization, so thinking of these things as opposites of each other, deprives anyone who might have to deal with a combination of either recurrent or chronic mental illness diagnoses from the possibility of improving aspects of their mental health. And so what this is basically arguing, I guess, is saying that if you're someone like my friend who lives with anxiety, and he's going to live with that. It's a recurrent thing for him. It comes and goes. This idea of, like being cured is not something that's kind of on his radar, at least right now, and same as Santino there. Then if we think about it as a bipolar thing, they're kind of in the negatives. Maybe they might at moments get it, from -10, they might get to -2 or to 0. But if they're always living with mental illness, then you've kind of deprived them of the opportunity of feeling well, which the dual-continua model doesn't do, because it has space for someone to have high levels of well-being with a mental illness. And I think the last paper that I'm really showing you here, there's some assumptions. We don't have to go into this. The point is with our student, Jackson Mason Stevens, who's gone on to do beautiful things in Perth, as he's doing them right now. He spent his honors year really thinking about a theoretical framework and the sort of the assumptions of a bipolar versus a bivariate or a dual continuum model of mental health, and what we should be doing to test these two models. And I guess the point is, we might be wrong. We could definitely be wrong. We need the community to pick up this and really start testing it both ways. And the thing that I've always argued is that the data already exists. Most studies that focus on well-being also measure mental illness, and vice versa. So that opportunity for like a secondary analysis of data, which is what the Trumpeter team did, the data exists. We could actually be running these analyses tomorrow. So I hope that someone can pick that up and go ahead and do that, please, because it has really meaningful implications. And so, just to finish off, I probably should have done this earlier, but some of the big implications of the dual continuum model of mental health the big one that we've spoken about so far is this idea that, again, it's overly simplified, but if you're someone in this quadrant here of having high level of well-being with a mental illness, that opportunity or that possibility doesn't exist in the single continuum approach, that you can't be both well with a mental illness. And so, I think the biggest pushback we get from people is like, say, going back to the Andrew Santino case is, when he's feeling down, he probably doesn't feel well. Like it's impossible to imagine when he's having like a depressive episode. And I think my point here is that you're probably right. You are probably right. But the question is, what's the window that we should consider? Should we consider in the absolute moment of your lowest low, or should we think about it as a week or 2 weeks? And the reason why there's more to the story, I guess, because there's sort of like psychometric implications, which we discuss in some of the papers, that the time frame that you open up can influence the sort of the bipolarity of this or the separateness of these two concepts. But let's not go into that right now. The idea is that what's most meaningful to a person, almost like to tell a story about themselves. Particularly, and I reference this stuff all the time in our paper, is this chime model, this idea of personal recovery. This idea that it's kind of like a human-centered approach, thinking about the person. So shifting away from what they call clinical recovery, where, a clinician has told you, yes, you are diagnosed. Now you no longer have that diagnosis. You have recovered. It's this idea of a personal recovery. So achieving goals that are meaningful to a person living with a mental illness, because we know so many are chronic or recurrent. So this idea that, a clinical recovery is kind of unlikely for that person. Instead, they have this chime model, which has come out of, I think, Australia and the UK, which stands for, I think, connection, hope, identity, meaning, and empowerment. And so the dual-continua model is really the only model that allows for this idea of a personal recovery, in my humble opinion, because so many of those aspects of that chime model are well-being aspects. So the idea that it's possible to build your well-being despite a mental illness is really important. And on top of that, I guess we've showed in my PhD in a paper with Corey Keyes, which is kind of an exciting thing for me, this idea that actually if you follow people who improve their well-being over time, people who have a diagnosed mental illness, and you follow them over time, they're actually more likely to recover from that mental illness in the future. And there's a couple of papers who have shown that. But again, it is a complicated story because it's not always true for all mental illnesses. And there's a nice paper that actually came out at the same time as our recovery paper by colleagues of ours in the University of Twente, Marijke Schottines Dijkstra, I guess I should say her whole name, who basically showed that it didn't look to be the same. This idea of recovery didn't look to be the same when you compared sort of anxiety versus depression, for example. And so I think really what I'm calling for is lots more research in this space to really understand the conditions by which, or the conditions where the dual continuum model is true, or the conditions where the bipolar model is true, because both are really important to understand. And you don't want to, like in both, in a scenario, say, where the bipolar model is true, although I still believe you need to have an overarching, you have to allow for the possibility of the dual continuum model. If the bipolar model is true, then some of the criticisms that I've leveled at it are no longer criticisms, and you wouldn't then want to be, incorrectly using resources because of that. So really getting to the bottom of where is this most relevant for which mental health and mental illness conditions, levels of severity, these sorts of things all make a difference. And so it's really important for us to get to the bottom of this. Some other implications, I guess that's really the big one, but this idea of really, like, particularly for measuring well-being as well as mental illness, because in the sort of the bipolar assumption, we sort of assume that we can measure one or the other, and that's telling us all the sort of relevant information about whichever one we didn't measure. We do need to have high level, we do need to be measuring both so that we can be assessing whether these things are basically separate or not. I think that's it from me. Let me look at my notes. I think that's it. Thank you to, thanks for listening, basically. If you've liked this, if you totally disagree, I want to hear from you. Check us out on YouTube. We've got a new home at the Be Well Co on YouTube. So if you check that out, Be Well Co, you'll find the podcast videos are there. Follow us on Spotify. Give this a like wherever you're watching it, because I really want to get this big. So I really feel passionately about this model. I want this to be out there. I've been really pleased to see that the dual-continua model, it's actually cited now by a few mental health commissions across the states. Headspace sites are Origin, Beyond Blue. These are all like our big three mental health kind of peak bodies or organizations. So it is gaining traction. And most importantly, I think when we present this, particularly to clinicians, they kind of look at it and go like, yeah, I mean, this is how I act. I act as if this is true. It's the problem, I guess. So this is not really, it's a funny thing where we're fighting an invisible enemy in a sense, and it's not really an enemy, but we're fighting, we're chasing at shadows basically, because everyone agrees, I think, that this is mostly true. And this is how most people act and work. And yet there's still some gaps in the system basically. And so that's where I think we can do a lot of good. So yeah, follow us, check us out, contact me on LinkedIn. I really want to hear from you. I want feedback. Would you like more of these kind of breakdowns on topics? Thank you. Thanks, and have a great day.